This podcast is sponsored by Eli Lilly.
Dermatologists like myself, I really care deeply about seeing, respecting, and treating all skin tones. And when we disregard it, that's when our patients might end up with not the best outcomes. I challenge you to put the word psoriasis or AD in Google and see how far you have to scroll to see any other shade other than white, fair, Caucasian.
So I think hopefully we're seeing a movement in the direction to be more inclusive. And I think that's definitely happening within clinical trials in dermatology to try to make sure we are looking at how everyone reacts potentially differently.
And if you're on the patient side of it, you're going to think, you know what? That's probably not what I have.
Welcome to Derm-It Trotter. Don't swear about skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter Don't Swear About Skincare podcast. Today, we are going to tackle a very unique topic that's been hot in the dermatology literature, but then also for a lot of you listeners out there, you've been asking me questions about skin tone and what does that mean for certain skin conditions and how do you care for your skin. So we're going to really get into that topic a bit more so that we have a greater understanding of what it means. I have a special guest here with me today, Dr. Mona Shahriari. She's a board-certified dermatologist, an associate clinical professor of dermatology at Yale University, and in practice with Central Connecticut Dermatology. And she's an expert in psoriasis and also has a great clinical interest in darker skin tones and diversity of skin tones. So welcome to the podcast.
Well, thank you so much for having me, Shannon.
Well, I know this is something that we've seen, as dermatologists sort of taking center stage, and I think it's been long overdue. But also in clinical practice, I have patients coming in saying, what exactly do you mean by tone of my skin? Or what is this whole skin tone diversity concept that's sort of starting, especially I think, for dermatologists. So how do you explain that when somebody asks that question?
Well, it's interesting because sometimes when that concept of skin tone comes out, when I'm doing a skin check, my goal is to understand what is your risk of skin cancer. And a lot of times patients are taken aback. But when we're talking about skin tone, we're really talking about fairest porcelain to the deepest ebony and really everything in between. And really thinking about that skin tone diversity is just acknowledging that the spectrum's not only vast, but culturally, socially, and in this case, medically significant, because that's what it comes down to in our day-to-day clinical practice. But it really does help shape individuals' identity, certain beauty standards, the way diseases show up on the skin, which is why dermatologists like myself, I really care deeply about seeing, respecting, and treating all skin tones and acknowledging it. Because I think sometimes when we disregard it, that's when our patients might end up with not the best outcomes.
Yeah, and I like that too, because you talk about just, more than the medical piece. Because I think, some of the folks listening, especially dermatologists and everything, I'm trying to figure out how this like interplays medically, but it's much more complex than that, as you just talked about, and how people identify, and then those kind of social and cultural implications, which I think, some of our patients are aware of, or, historically, they've struggled with, changes in tone, or maybe they've had a skin condition that, somebody didn't really recognize at first because it looked different just based on their skin tone. And I know, kind of getting into the academic nitty gritty, can you talk about why do we see this variation? Because a lot of people are like, why do we have this vast variety of skin tones that you see just in humans? Is there a reason for this? And, maybe even evolutionary.
Yeah, so this is one of my favorite biology meets anthropology stories.
Mm-hmm.
So really at the root are the melanocytes, the cells that are making that pigment in our skin. And when they produce a lot of pigment, we're going to get darker skin tones. And then when we don't have as much pigment, we're going to get the lighter skin tones. But really, evolution has fine-tuned what our melanocytes do. Near the equator, where that UV radiation is intense, darker skin developed as that protective armor against those intense UVA and UVB rays. Near the poles, the lighter pigment allowed for the UVB-induced synthesis of vitamin D. And if you look at in between the poles, you have that gradient with tanning really protecting individuals against those spikes in UVA, UVB. And the way I like to think of it is our skin is literally a living living history book of where our ancestors came from. And it's funny because sometimes when I see my patients with atopic dermatitis who have an ancestry that takes them closer to the equator, well, when they see me up in Connecticut, which is a much higher latitude, they end up with dry skin and all these other sequelae. And I tell the parents, you know what? Your child's skin was meant to be closer to the equator. If you take them where their ancestors were, you're probably not going to have this atopic dermatitis.
Right. Well, and I love that you go into that, because I think people don't understand it truly is a function of biology and where we all kind of originated from, and sort of how that changed over time and how our skin adapted to those changes. I think that's just fascinating. If you just look back the historical, biological context, and then over evolution, and then you're right. Once you put us into different environments, I have heritage kind of more Northern European, and I always tease my husband. He is Hispanic and has Italian ancestry, and we always talk about how our skin tolerates different things. And I said, I don't have many shades of tan. I basically get red and maybe a slight hint of color, where he just laughs the whole time because he just gets this nice golden shades and pretty dark. And since he's actually moved to the States, big variation, you can see that. And I think that connection is really important for people to understand where it comes down to biology and how it may impact skin disease. Now, we've gotten a little technical, I know, on the derm side, and we even talk about, scales or Fitzpatrick type. And I think some people, I was even talking to some colleagues who are like, I've never even heard of the monk skin tone. I know these Fitzpatrick types. And I was going to have you talk more about them, from the standpoint of, what does it mean maybe on the dermatology side, but for patients, is it important they kind of know where they fit within sort of these, parameters that we've created as dermatologists?
Yeah, exactly. So we'll go into the Fitzpatrick skin scale in a little bit more detail, but that's what a lot of us are used to. And those of us who see a lot of patients with skin of color, we've realized the limitations of that scale. And it's funny because several years ago, they put international skin of color experts in a room to see if we could come up with a better scale that was more all encompassing. And guess what? We come up with anything better than what we currently had with Fitzpatrick scale. But the monk scale is actually a really interesting scale that you mentioned. It's relatively new. It came out in 2023, and it's a more modern, inclusive way of categorizing skin tones that was made in partnership with Google. And actually, it wasn't designed to be used in clinical practice. It was designed with the goal of improving machine learning, artificial intelligence, rather than specifically for skin pigmentation quantification. And it uses 10 shades to capture the real world diversity that we see in skin tones. And the way I like to think about it is, if you're doing a Google search for a physician in the year 2025, you want to see the heterogeneity of the types of physicians you would see in clinical practice. So now Google can actually use this monk scale behind the scenes to give you different types of quote unquote physicians that you see in that search. So I think it's really interesting to be able to use it that way. And I think that it's also over time going to help improve the diversity that we see across a lot of public images, searches. Because what I find challenging when I see patients with skin of color is when they're trying to diagnose their own skin conditions, they go online and maybe they research psoriasis, they research atopic dermatitis. I challenge you to put the word psoriasis or AD in Google and see how far you have to scroll to see any other shade other than white, fair, Caucasian. And if you're on the patient side of it, you're going to think, you know what, that's probably not what I have, because my skin and my disease is not represented in these photos. And then all of this leads to delays in diagnosis, misdiagnosis, undertreatment. So I do think the monk scale, even though not perfect, it does offer us another way to be able to better categorize the diversity of tones that we see every day.
It's kind of funny too, because the collaboration with Google and knowing about that, we're always teasing about the challenges with Dr. Google. I think this is one of the times where there could be a nice benefit of a collaboration. And you're exactly right. All patients come in that have darker skin. They'll say, I believe you have psoriasis, you have eczema. And they'll say, no, I looked it up. I don't look like that. And it's true. In the room, I'll have an iPad and I will Google images and try to find an image that may match their skin tone. And it is an extreme challenge. So the fact that this is an effort that's being worked on to be more representative of the different skin tones and how skin disease can present, I think that's fantastic. And I have to give, kind of credence a little bit to Google there, where I know we give them a hard time for sometimes interfering with some of our diagnoses or how we want to treat patients. But this type of thing could definitely be beneficial for our patients.
Absolutely. And I actually think as a specialty, the AAD is doing a really nice job of improving the skin of color presence in their databases. I'm actually part of the physician education committee of the Skin of Color Society, and we're working with the AAD to see if we can just increase the diverse presentations of various common and even uncommon skin diseases within that database. Because if residents are trained on the various ways a disease can present, then when they're attending, they can actually diagnose those conditions correctly, initiate treatment more effectively. Because the reality is, just like you and your husband, your children are not going to be that classic fits one, fits four. Everyone is now a mix. And I like to call it a spectrum of different skin colors that we're going to be seeing in clinical practice. So we do need to get better at understanding what disease is going to look like across the spectrum of skin tones.
And the training is very important, as you mentioned too, because depending upon where you train demographically, what part of the country or region, where your clinic might be, who happens to walk through, your training could be very one-sided. So that's amazing that AD is helping to work on that, to expose, future dermatologists to that, so they can help our patients, because you never know where you might land for your career. And so your career where you're practicing can have a very different spectrum of skin tones than maybe where you even trained. So to help us all be better prepared for that is pretty amazing. Now, I was going to touch a little bit upon that Fitzpatrick piece that you mentioned, because I know we still traditionally do use it, for, sometimes people are looking at for a light therapy. Maybe if somebody comes in and deciding how they're going to approach a patient and utilizing it more of an assessment tool. I think for patients, they're like, I don't even know who Fitzpatrick was or what a Fitzpatrick type would mean. Do you mind kind of talking about that, maybe the limitations, and maybe also where there still might be a use for it too?
Absolutely. So I remember when I was in residency, I would have a patient that I would see come out of the room and say, this is a 59-year-old female with Fitzpatrick skin type 2. But when you think about the Fitzpatrick skin typing scale itself, it was a study back in the 70s and first developed, and it was to accurately dose phototherapy for patients that needed UVA or UVB therapy for their skin disease. We just wanted to make sure that the dose of phototherapy wouldn't cause burning or harm to the patient, which was a very altruistic reason for it to be developed. And interestingly, it was actually first developed for lighter skin tones. So Fitz 1 through 4 was what that initial scale included. And then we later realized we need to expand it to include some of our more melanin-rich patients. That's where Fitz 5 and 6 were added to the mix. But as somebody who sees a lot of patients with skin of color, 4, 5, 6 is really not enough to categorize the heterogeneity of patients that I see in everyday clinical practice. But when we think of the different 6 categories that we have, type 1 is the category that always burns and never tans. Think of this person who has red hair, pale skin. Type 2 is somebody who burns easily, tans minimally. Type 3 is someone who burns and also sometimes burns, but tans uniformly. And then type 4 rarely burns and tans easily. That's where I fall in. And then type 5, they rarely burn, they're deeply pigmented. And type 6 never burns, and they tend to be profoundly pigmented. And it's really incorrect of us to walk into a room and just decide based on the color of the individual what that Fitzpatrick type is. Because the way you should really do it is use a colorometer, which is just a device that you put on the inner surface of the arm, which is an area where sun isn't present, just to get a better gauge of what that individual's skin tone may be. Now, I mentioned that I'm type 4, and that's how I categorize myself based on how my skin reacts to the sun. But when I use the colorimeter, I actually came back as a type 3. So it's really interesting for me as a dermatologist. Now I'm conflicted, like which category do I really fall into? But I think that if Dr. Fitzpatrick knew how this scale was being used in day-to-day clinical practice, he'd roll over in his grave, because that was not the intention really when we first started out. But I do think it's something. It gives us an idea of what is this individual's skin tone? Do we need to be more concerned about the behavior when we put them in front of phototherapy, if we're doing laser on them? But as I mentioned, it is far from ideal. And one of the reasons why I don't love some of our studies, clinical trials that are looking at skin of color, is because they gradate patients and put them into these categories of skin of color based on having, say, type 4, 5, 6 skin. But the reality is you could be skin of color based on your racial and ethnic identity and maybe have skin type 2. Now you're going to be excluded from a trial, even though your body and your skin's behavior when it's exposed to laser or light may be a little bit different than somebody who's a true type 2 Caucasian person.
It's very interesting to point that out because I don't think a lot of people would think of that, right off the bat, whether it be the patient or sometimes even as the clinician. I think a lot of times that there's a disconnect there. So that's a really important thing that you highlight. And mentioning the clinical trials, when we have inflammatory disease, in particular psoriasis, I know, which is kind of a passion of yours, atopic
Yes.
dermatitis, when we're thinking about, skin tone, Fitzpatrick types, I mean, we kind of talk more about how, they obviously impact, with Fitzpatrick, your risk, of burning or likelihood of tanning, looking at the skin tone, better representation. How does it all kind of get put together when you're looking at just different skin conditions and how they might actually look different, or maybe even the pathophysiology have some differences based on diversity of skin tones?
Yeah, so I think the clinical presentation is probably one of the main places where having melanin to your skin is going to differ. Because when we think of psoriasis, for example, to use your previous example, we think of erythematous plaques with silvery scale. And when you look up erythema, you're thinking red and pink. Those are the colors that we're used to. You Google it, that's what you see. But when we're dealing with melanin-rich skin, even someone who has type 4 skin, you aren't necessarily seeing those shades of red. It might be dark brown, it might be violet, it might even be gray. And that's where it's really important for us to understand that the erythema doesn't always look that classic red or pink that we're used to in a textbook. And the reason why it's important to identify this, one is you want to identify the disease correctly, but two, erythema is also used to assess disease severity in plaque psoriasis. So if you're not seeing those high levels of erythema, you may now underassess and then undertreat somebody's condition. So it's really important for us to really broaden our color palette when we're examining patients with melanin-rich skin with the darker skin tones. Now, the Fitzpatrick skin type comes into play when I'm doing phototherapy for my patients with darker skin tone, because some patients may not want a systemic agent, topicals may not be sufficient. And I do indicate the Fitzpatrick type, but because phototherapy really wasn't studied in patients with, say, type 5 and type 6 skin, we're at a loss as to what is that perfect dose? What is the perfect time underneath the light to get a desired effect? So it's not a perfect model. That's all I can say.
No, and that's really good because I think for patients they might have an assumption too. Oh, this has been looked at and thoroughly studied, and even as the dermatologist, I think historically going back, you look at those demographics and makeups of our clinical trials, and there obviously is an imbalance there where we don't often have patients with diverse skin tones included, and trying to make that translation into the real world that it's definitely going to work the same, we're going to have the same outcomes, really isn't fair, and it sort of puts it back I think on the dermatologist like yourself. You're trying to figure out based on your clinical experience and what you're estimating without those studies to back you up on what might actually be beneficial for the patient. So I think hopefully we're seeing a movement in the direction to be more inclusive. And I think that's definitely happening within clinical trials in dermatology to try to make sure we are looking at how everyone reacts potentially differently based on their skin tone. And, back in the day too, they would talk about how they studied cardiovascular disease or heart attacks in women versus men. A lot of these studies were done, just if you look at gender and Caucasian men, and they found over time, well, women present differently now too. They may not have the classic, radiating pain and on the left side or elephant pressure on the chest and all the things that we've learned. I think we're becoming just more educated in how, people are very different and how we present with certain things. And it's important to understand that so we can recognize it, obviously, and then treat it more effectively as well. And making patients aware of that too, and making them
Yeah.
feel more included in the process.
Yeah, it's so interesting you mentioned women and the differences because actually it wasn't until the 90s that women were included in clinical trials. Before that, the assumption was that women are just like men, but with different sex organs. And I think it was an aha moment when we realized, actually, like you said, there are different diseases that present differently. Different therapies that can be a little bit more challenging in one gender versus another. But to your point, I think that's where the skin of color piece becomes very relevant in our clinical trial design because our trials are supposed to be a small population that represent the larger group so we can take the results from that small group and apply it to everyday clinical practice. But if you have one group that's being overrepresented and one group that's being underrepresented, not only are you not able to get very accurate results on the efficacy and safety of a therapeutic, specific, but also you don't understand what are other barriers to a skin of color patient getting the care they need. Because many of our patients, mistrust in the healthcare system is huge. If I'm giving my Caucasian patient an injectable as an option versus my skin of color patient an injectable as an option, it's a very different conversation, because patients who are used to hearing about being practiced on and being used as mice, so to speak, in different trials back in the day. Like, we did not do a good job with our skin of color patients, say 50, 60 years ago. And that's why a lot of our rules and regulations for patient protection were created for clinical trials. But that inherent distrust in the medical system is there. Cultural competence, like when you go into a room, somebody from a certain racial and ethnic background, you have to deal with that individual's preferences and their preconceived notions a little bit differently than somebody who may come from the same background as you. And I always say, what you think you know about someone and that individual's background may not apply to the person sitting in front of you. So again, I always check my notions at the door and try to walk in the room with a clean slate, because those are all the ways that we can ensure we're delivering that more inclusive care to our patients beyond just therapy selection.
And that's great advice, because I think we all have our own assumptions, inherent biases, and experience clinically that can really influence how we practice or approach a patient. And you're right, leaving that at the door and just trying to look at the person and their condition and have them help educate us and walk through, what's important to them, their values, and then trying to get a better understanding. That definitely important to build that relationship. And as you said, I think will result, in better treatment and trust for that patient if we build that rapport and kind of walk in their shoes, so to say, although we can't, really walk in everyone's shoes. Everyone has different experiences, but to be more aware of that and really strive to do better, I think is so important. And especially when we're treating patients, in skin, and the very thing that we deal with, and seeing all these variations in skin tone as well. And I know we talked a little bit about presentation. I was going to have you comment a little bit about, because I think people just assume, it might look different. In the last few minutes we have, can you talk a little bit about what data might be showing, or research showing, that actually there's some physiological differences, potentially with psoriasis or atopic dermatitis, that we might see in various skin tones as well?
Yeah, actually, there's a lot of data on the horizon. One of the studies that was done by Johnson & Johnson, looking specifically at patients with skin of color who were being treated for their plaque psoriasis with guselkumab, aka Tremfya, did find some biomarker differences in our patients in terms of how their body responded to therapy, some of the comorbidities that they dealt with. But we actually have more data, I would say, on the atopic dermatitis side, because we are seeing differences in terms of just the genetic makeup. We always think of filaggrin loss of function mutations being the common thing in AD, but it's common in Caucasians. When you look actually at African Americans, we see uncommon filaggrin variants that are going to be linked to more persistent symptoms. Also, transepidermal water loss is more of an issue in our patients with skin of color than our Caucasian patients. This is why picking the right moisturizer in somebody with melanin-rich skin is going to be a very different conversation than someone who has Caucasian skin. And a lot of people, if you're telling them, you know what, that moisturizer that your mother and your grandmother and great grandmother use is not going to be okay for your skin, it's a tough pill to swallow. So again, that cultural competence when you're having those conversations is going to be very key. And there's different presentations when it comes to AD, whether you're looking at the morphological presentations with nummular eczema or extensor surface involvement, scalp involvement, all of those being different in individuals with skin of color. So there are a lot of genetic as well as just clinical endotypic and phenotypic presentations that differ in our patients with skin of color versus our patients who are from Caucasian backgrounds. And being aware of that can help us better diagnose. And I tend to biopsy my skin of color patients more because they don't read the textbook. Mm-hmm. And I want to ensure I know what I'm treating before I start on a therapeutic journey.
I would totally agree with you. I feel like I do biopsy more because definitely there's presentations that and the heterogeneity that exists out there. And especially I would say, although for time's sake we won't talk about it, for skin cancer, which is a whole nother, topic in our patients with diverse skin tones as well, because I do feel like often it's missed or underdiagnosed, or there's also perceptions, both I think on the dermatologist or clinician side, as well as sometimes even on the patient side, that with darker skin types, I'm not as susceptible to have skin cancer as well. And we could talk about kind of the differences there. I know for time we don't have it, but I think that's really important that people approach, the individual patient, look at it, and if we're suspicious of something, that we treat it like anything else, regardless of kind of how the patient comes in. But keeping in mind with various skin tones, things can look quite differently, as you mentioned. Well, I want to thank you so much for coming on the podcast today. This this is a topic that I know a lot of our listeners were asking questions about, and understanding just, is there really science behind this, and why do we see this vast array of skin tones and the implications it has for dermatology, diagnosis of skin conditions, treatment potentially as well. And your insights are very helpful, I think, to kind of provide a clearer picture on how we can actually move forward to include this, as the dermatologist, but also on the patient, to understand how their skin might behave differently as well.
Yeah, no, thank you so much for having me. One last thought I want to leave our audience with is it's really the skin is the most visible organ. That's why I think there's a lot of psychological impact when someone has skin disease, because you can see it. But the benefit is when things get better, you can also see it. And it's really where medicine meets identity. So for our patients, understanding diversity means being seen, both literally and figuratively. So as clinicians, it's really our job to ensure we are taking care of the whole patient, not just having tunnel vision to one disease process, so it can really optimize outcomes.
I love that. That perfectly said, and a great way to end our conversation today. Well, thanks again for coming on the podcast. For our listeners out there, if they want to find out more about you, how can they locate you?
So they can follow me on Instagram, Persian Skin Doc, and LinkedIn as well as just taking a look at my profile on my practice page, centralctderm.com. And thank you so much, Shannon, for having me. I had a great time.
Well, it was a pleasure, Mona. We'll have to do it again sometime. And thank you all for listening, and stay tuned for the next episode of Derm-It Trotter. Don't swear about skincare.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermatologist.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.